Hello, I'm Eric Kerfoot. This is our presentation for estimation of cardiac valve annuli motion with deep learning. This is work done at King's College in conjunction with the University of Michigan. So, our motivation is we want to track where the valves are in the heart throughout the cardiac cycle. So the valve annuli are not stationary, they do move throughout the cycle, and the actual shape of the annulus can actually indicate certain pathologies, and the amount of motion can also indicate certain pathologies. We're also interested in knowing where the valves are located in images so that we can construct meshes more accurately than we can just with segmentations. So to do this, our objective is to train a system to be able to predict the valve leaflet insertion points in the three long axis views. So to understand morphology in a diverse cohort containing both healthy and volunteers, we want to be able, healthy volunteers and pathological patients, we want to be able to identify where the valves are in these three views. So we have a certain number of landmarks that we want to be able to predict directly from the images. So for doing this, we can do our model fitting as well as be able to calculate biomarkers to give some assessment of heart function. So as you can see here on the left, we have the three long axis views and where the landmarks are to indicate where these valve points are. And on the right, the kind of meshes that we can then create using this kind of information. Our data set consists of 8,500 odd images that have been annotated by expert annotators to include these 10 landmarks. Our training set consists of HCM and infarct patients taken from 3 different sorts of scanners, so we have quite a broad range of images to use here. Our expert annotator annotate all the images, and we had further annotators annotate a smaller number to be able to do inter-observer observations. So we have 10 landmarks. Again, 6 of these are going to be for the mitral valve, and then 2 for the other 2 valves we see in these views. To do this prediction, we train a neural network in PyTorch to do this for us on a per image basis. So this 2D network, it consists of a series of convolutional dense blocks that consists of 3 residual units essentially chained together in a sequence. Each residual unit takes as input the outputs from the prior units as well as the original input to the whole dense block. And each subsequent residual unit has convolutions with increasing dilation factors. So each subsequent one has a dilation factor going up by a power of 2. What this produces in the end is an output from each block which contains information at different resolutions. So different features can be picked out at the different resolutions by the different dilated convolutional kernels. This then allows us to collect information at different resolutions together and then pass that along to the next block after being downsampled through a convolution with a stride of 2. So each of our sequence of dense blocks will amass information at different scales within the image and then condense that and pass it along to the next block in the sequence. At the end of our sequence of dense blocks, we have a series of small neural networks that each predict a single location in the set of landmarks that we want to predict. So for each image, we're going to have a prediction for all 10 landmarks, and of course not all occur in each image, and so the network must learn which ones to attempt to predict and which ones to leave as 0. And these individual networks would do that for us. They consist very simply of just a convolution followed by a fully connected layer, and this then reduces the information coming from our dense blocks down to our final prediction. So for 10 points, we have our 10 different subnetworks to do this for us. We trained this network on mini batches of 400 images selected randomly from our data set and augmented to create a total of 120,000 iterations consisting of 300 epochs of 400 steps. For each image that we take from our data set, we apply randomized flip, rotate, shift, zoom, transpose, and deformation operations to perform our regularization for us and, of course, to introduce more variability into our data set. And these operations, of course, operate on the image and the landmark pairs together so that our landmarks retain their position in the images. Our images are also further modified using just stochastic additive noise, some case-based corruption using a dropout method, and variation of intensity and contrast. To train, we use the Atom Optimizer with a learning rate of 0.0001. And during training, at the end of every epoch, we also will apply our network to our training set. Using the outputs of that training, we then predict a loss. That loss is then used to adjust the probability that images will show up in each mini batch. So the images which are doing poorly, which the network is predicting landmarks for poorly, will occur more often in each randomly selected mini batch. In this way, we implement a curriculum learning approach to be able to enforce to the network that we want to remember these particular images and learn how to predict better from them. So on to results. we compared our approach to two motion tracking methods where we will start with a manually chosen initial point at end diastole and then track throughout the whole cardiac cycle. So we use an algorithm that comes with a MATLAB package and motion tracking with the MIR-TK package. We then also compared this against some inter-observer variability for those images which we had multiple observations for. So as we see here, we have, for our approach in gray, we have our predictions for some of these, which are doing quite a bit better than the motion tracking or even compared to inter-observer variability. And for a few of these, particularly the aortic valve, we're doing a little bit poor in the sense that we have quite a bit more in outliers going above the range that the motion tracking examples show. For the tricuspid valve, we have also a case where we're doing a little bit better and a little bit poorer in two different locations. What this demonstrates in general is that we have a more predictable result. We don't have as many wild outliers as some of the motion tracking methodologies seem to exhibit. Although the differences in the inter-observer category, though, can be quite high in some cases. But we are still within roughly the range of what we expect for those. So what can we use these things for? So we have our 4 different categories of images, hypertrophic, dilated, infarct, and healthy. And we want to look at the landmarks for these and be able to use the landmarks to look at some of the biomarkers we can get from these images and from the actual movement that the landmarks actually tell us. So we can use this to measure, of course, the diameters of the annuli of the individual valves. We can look at long axis motion, and we can also look at strain. So looking at motion in particular, we can calculate the MAPS, TAPS, or MAPSI-TAPSI, however you want to care to pronounce that, measure of the amount of absolute displacement for the valve insertion points over the cardiac cycle. So as the graphs here show, for the healthy volunteers, we see quite a bit more. So these volunteers will have less stiffness in their hearts, and so they'll get stronger contraction. And so we see a greater displacement on average. For the infarct patients, of course, we see the least of all. We'd expect infarct to cause stiffness in areas and for there to be parts of the heart that are just scar tissue and are not signaling to the surrounding tissue around it. So we would see this kind of stiffer behavior here. For the other conditions that we are looking at, the ranges are quite a bit wider, and so it's not really a feasible thing to use to try and predict or stratify, but can help us possibly predict some severity values. Looking at strain, these are plotted from the landmark points to manually chosen apex points throughout the cardiac cycle, and so this looks at the strain of the individual landmarks on the individual images that we looked at. So for each valve, we have, for mitral, our 6 different landmarks from the 3 different views. For aortic and tricuspid, 2 landmarks each. And they all roughly correspond to one another throughout the cardiac cycle. So they exhibit the most strain as we go towards end systole, and then throughout relaxation, they more or less keep up with one another. And then back to the end of the cycle, they converge once again. So this is demonstrating that we have some consistency between our predictions and that our strain calculations appear to be quite reasonable and quite physiologically accurate for what we'd expect. Looking at the actual accuracy versus our observer 1, so the red line is the line of fit between our predicted points and the points predicted by observer 1. So the farther our line strays from the diagonal, that shows a bias towards either over or underestimating essentially the amount of strain that there is from tracking our points. So we want to be as close to the diagonal as possible. That means that we're as close to the actual predicted values in terms of strain. However, we are doing better in some cases when we compare observer 1 to observer 2. So if we do the same comparison and look at the strain that we would get from 2 different observers estimating landmarks, we see some divergence from the diagonal. In some cases, our predicted points are doing better. In a few cases, they're doing a little bit worse. For the aortic valve, we suspect that has something to do with the actual interference from movement of blood pool. So some artifact from that is perhaps throwing off our prediction. In general, though, this is demonstrating that we're getting strains that are quite close to what the observer 1 and observer 2 are actually predicting to be present given the landmarks as they've predicted themselves. So that's been our talk. Thank you very much.